Hello and welcome to the Foot Forward Wednesday webinars. My name's Georgina Frank, as many of you will already know, and I'm a podiatrist and the Foot Forward Project Officer. Before we start, I'd like to begin today's webinar by acknowledging that we're living and working on Aboriginal land and recognise the strength, resilience and capacity of Aboriginal people on this land. Today, I'm on the land of the Gadigal, Wangal and Bendigo clans, which are part of the 29 clan groups within the Sydney metropolitan area, referred to collectively as the Eora Nation. I'd also like to acknowledge all the traditional owners of the land and pay respect to Aboriginal elders past and present. Okay, so thank you for joining us for today's webinar. I'm really pleased to introduce a wonderful woman, Michaela Watt. She's a podiatrist and head of the St. Vincent's, or has been head of the St. Vincent's Highrisk Foot Service, and she's also the NADC Highrisk Foot Service and Foot Network Project Officer. Hi, Michaela.
Hi, Georgie. How are you going? Hi, everyone. Thanks for joining us today. Should be a really great session.
I think it's going to be wonderful, and it fits in really well with Joel's session. So I'm going to hand over and we're going to start the presentation. See you soon.
Hi everyone, welcome to today's Foot Forward Lunch and Learn seminar. My name is Michaela Watts and I'm the Project Officer of the Highrisk Foot Standards and Accreditation project. So today I'm going to give you an update on the NADC Collaborative Interdisciplinary Diabetes Highrisk Foot Service Standards and Accreditation program. So the standards now have been released for about 4 years, and it's serving as a really good benchmark for services to identify where they're sitting against the national recommendations for high-risk foot care. The accreditation program has been running in conjunction now for about 3 years. What we're finding is it's certainly gaining a lot of traction within the high-risk foot community, which is really positive. We're really happy to see that there's lots of services thinking about going for accreditation, have been accredited and looking towards going through that re-accreditation program, which some services are up for next year, and then obviously the year after and so forth. What we've developed over the last couple of years to help services in preparation for the accreditation process is the gap analysis tool, which is available for download on our website. This is designed for services to, at their own time, go through the process of reviewing each criterion, looking at the evidence that's needed to support their claims of how they meet each criteria, and also just taking the time to get all of that information together. Sometimes we know that that services sort of have those processes in place, but as we often say, if you or that lead podiatrist, for example, one taps lotto and walked away from work for whatever reason, could someone step into your role and know exactly what to do and how to do it? So it gives people sort of that time to document anything that might be missing, or those policies and procedures, and document them clearly and put them into a bit of a high-risk foot Bible, so that anyone who came into the service after you've won your millions can step in and take on your role with no problems. So we've found also with the high-risk foot service standards and accreditation, we've found that it's certainly breaking down those barriers between services. We're also wanting them to find the enablers that are really helping services undergo that accreditation. So we want to learn from services that have gone through the process, how they found it, what they've found really beneficial, and hopefully other services can learn from that. We're also finding that services who are new within establishing a high-risk foot service can come to NADC, and we can get them in contact with people around Australia that might be excelling in the model of care that they're looking at. In particular, we found this in Victoria last year in amongst the COVID pandemic, that we sort of thought, how are we going to tackle high-risk foot, either with telehealth, that we probably weren't as comfortable using in the service that I was in, or it wasn't as commonplace. So we certainly could look to see who had done that quite well, and that had been accredited for that excellent service delivery model, and get in contact with them and work out how they'd done it and learn from their experiences as well. So we're really hoping that this process will break down a lot of those communication barriers that may have been there for whatever reason. The standards over the last year in 2020 had undergone a full review from our panel of experts, and we've released the version 2.0 that was released at the start of this year. In conjunction with that, Dr. Joel Lashoots has been really pivotal in developing the Australian Diabetes High-Risk Foot Database, which I know a lot of services have registered their expression of interest, going through the ethics process, or are now live and collecting data for their active data service, which is really, really great. So it's really promising. I've used that database myself in the service that I'm at, and the reports that it can generate and the information you get is really wonderful, and hopefully that will direct service development and identify service improvement areas and things like that. It'll be a real game changer. So in regards to accreditation, there has been 28 services that have expressed interest over the past 3 years. 7 have been awarded Centre of Excellence, 10 have been awarded Core Accreditation, 4 withdrew from the process for whatever reason, or for a number of reasons. 2 were not awarded accreditation, and 2 services at the moment have undergone the accreditation process, and then they're now sitting with the assessor reviewers, and hopefully we'll have that wrapped up in a couple of weeks. There are 3 services currently undergoing round 3 of accreditation, and again that began towards the start of August, so about halfway through round 3 at the moment. This is our lovely colourful map of our services that have been accredited. It's nice to see a big spread across the whole nation. We're still missing a couple of states, so get in contact if you're from ACT or Tassie and you really want to look at doing accreditation. Certainly help you along the way and support you through that process. So hopefully in the next couple of years we'll have lots more dots, a lot more services accredited, and find this map being a bit more colourful than what it already is. Here with our Centre of Excellence awardees, you're going to see obviously some quite familiar names, and along with our core standard awardees as well. So the standards review that was conducted in 2020, the major changes were some clarification around the key team members that needed to be not just present at the appointment, but also present throughout the episode of care. So we just wanted to do a bit of clarification around that. We know that not everyone can be, not every discipline can be represented in that one appointment, and it might not necessarily mean they need to be present at every appointment, but they're certainly available and involved throughout the episode of care. There's been some grammatical changes that we've made throughout the document. We've also done some clarification around the emergency department referral pathways into high-risk foot services, and pretty much now we really want services to focus on, particularly with ED presentations, we really want them to know who to call and when to call them and get that high-risk foot into the high-risk foot service team hands as quickly as possible. So how those services navigate that is up to them, but we really want some of those really good processes in place that as soon as it presents to ED, it's in high-risk foot hands pretty quickly. Again, a big one that came out of the International Working Group recommendations is the use of SINBAG communication, the SINBAG communication tool as the preferred method for communication about high-risk foot issues between external services. So we've really tried to weave that through our standards and make that a pretty clear tool of use for services, particularly from GPs referring in. It's quite basic, but everyone can use it. There's no specialist equipment needed, and it's a really good idea of just how bad that foot is and how quickly we can triage that wound. Again, we did a bit of aligning Standard 8 to reflect our Australian Diabetes database as well, and the data collection tool. So that's just had a bit of reworking. Again, the same sort of points being collected, information points being collected and data being collected, but just aligning that similar wording and similar layout, things like that, which leads us to the development of the Australian Diabetes High-Risk Foot database. So I guess why would services want to be accredited? Well, I guess the important thing to note here is there are so many services doing such wonderful work out there in the high-risk foot space. We really want them to be represented and acknowledged for the hard work that they're doing. And this is certainly having an external organisation reviewing and accrediting them and benchmarking them against other services is a real kudos to them if we can accredit such wonderful services like that. Again, we certainly look at making sure we give services the opportunity to develop the resources that they need. And again, sometimes we have all the ideas in the world, or we think we'll get around to developing that educational tool or that information sheet that patients need. So sometimes this gives us a real, line in the sand to stop, reflect on those gaps that we currently have in our service and really spend some time on developing those. We know that, certainly sometimes seeing that foot in front of us each time is the most important thing, but also really making sure we've got those robust service policies, procedures in place to help us deliver the best possible care we can to our high-risk foot community. So we're really hoping that this process really allows services to develop the resources that they need to continue doing the work that they're doing. We really want to look at, as we were mentioning before, developing those national connections. We've certainly found over the last 18 months not being able to get together for our usual DFA conferences or our LEAP conferences from a podiatry point of view. We've certainly missed those face-to-face connections where you can talk about, different services, present the wonderful work that they're doing. So we're really hoping that this is another way that we can connect services together as best we can. Also, the ability to benchmark against other services and see how we're going as a service. So to look at what we do really well. And I think the funniest thing from my point of view, when helping services go through the accreditation process is getting them to identify that what they feel is probably what they do every single day, it's nothing special, is actually what makes them so special. I was talking to a service the other week who was undergoing round 3, and I said, you need to look at, what you do all day, every day that makes your service quite unique, because that's certainly delivering care to your demographic that, you've developed over years and years of working with that cohort. And they have their own TCC clinic that they run that's run by podiatrists. So the podiatrists put on or remove the TCC, manage the Charcot foot and reapply the TCC all within their own department. That's not really something that for me is, or from my experience as common knowledge, I've often worked with P&Os or plaster techs and things like that help us manage those TCC. So for me, I was certainly like, you need to highlight the fact that you do that your podiatry team or your high-risk foot service team works in that manner, and really promote what you feel is, oh yeah, doesn't everyone do that? Well, no, not necessarily. So you really need to highlight the things that your service does really well. Again, we really want services that are undergoing accreditation to make their directors of allied health aware, and also their heads of departments, so medical, surgical, things like that. We really want them to be invested and give you the time that you need to go through this process, and also to support the wins that when you do become accredited, that they can really identify and support you, and hopefully allow a bit more service development, or really help you with the key service improvements that you want to work on, and sort of they can have that background as to why you want the service to go one way, or the team wants the service to go one way. So we really want their investment as well, and to support you through that. Again, with accreditation, we do give you 8 weeks. We generally say it takes 2 to 3 days to fill in the accreditation package, but we do know that can, be spread over a number of weeks. It can take longer for whatever reason. So we certainly want, again, your managers, and I'm talking more from a podiatry point of view here, and I'll explain why that is. Generally, we find that podiatrists are the lead people who will undertake the high-risk foot accreditation. So we certainly want, involvement from your key players like your endocrinologists and your vascular surgery team, your ID physicians, your D&Es as well, to support you and to input into the whole accreditation program. So again, if you can get more people to be aware of what you're doing, hopefully they'll give you that support that you need. Again, we really want those services to be recognised for their service development and what they're doing. We want to identify the key players that are providing gold standard care, and again, allow other services to learn from your experiences and allow you to educate the rest of us on how you've developed your models of care or your certain processes and policies as well. We want to identify as well the differences of service demographics. And I guess that's really important, and that will probably come out in our data collection tool when we do a national audit and benchmark. And we really want to know how services are managing their specific cohorts. And I think that's, again, where we can learn from everyone and every service. So I guess the key learnings and experiences that services have found, we did a recent survey for sites who have undergone accreditation. We had 9 respondents, 7 of which were podiatrists who had been responsible for undertaking the accreditation package. We found that NADC is certainly becoming that conduit between services and connecting other services undergoing service development, which is wonderful. And again, we wouldn't have that ability if we didn't have services that had undergone accreditation and putting their hands up to say, yep, get in contact with us if we're doing great telehealth models and someone wants to learn how to do telehealth, or we've got a TCC clinic running and this is how we've done it. So we're really thankful for those services to put up their hand and have people connect with them, and they can have that open dialogue. We found that most services found that preparation was the key to it. So we had a couple of services, again, undergo that gap analysis tool and was really providing that beneficial information. And some services took, a good year in preparation before applying for accreditation. So again, it gives you the time that you need to identify what will be the most effective time for one to go for accreditation and to see how many gaps you have and fill all of those in before you put your hand up and go down that pathway. We found that the team approach on all fronts was the best option for everyone. So certainly looking even back from the gap analysis process to divvying up that between the team, get the whole team to buy in on that. And then also once you undergo that accreditation, everyone will hopefully be able to input and learn a bit more from that accreditation process. And again, remembering that this accreditation is quite similar to it's based on the hospital accreditation process that most tertiary hospitals go through on a regular basis. So again, it can really give junior staff that exposure and experience to undergoing accreditation. Again, we need executive support to ensure you've got enough time to complete this thing and it's set as a priority for the team to get done. Again, the data collection tool is a key to driving our national collaboration. And again, we're knowing that accreditation is becoming more commonplace, which is wonderful. So our survey results, the major changes as we've talked about, again, a clarification around our emergency department referral pathways, looking at our SINBAD communication tool and alignment of our standard 8s. The survey results that we conducted earlier this year, and again, we asked for services to give feedback at the end of the accreditation process, but this survey we delved a little bit deeper. We wanted to find out sort of a bit more direct feedback from our services that had undergone our accreditation process. The key elements, again, was having the time to go through the process, time for preparation. Patient services using that team approach was hugely beneficial. Having executive awareness of what the whole process was about and what the ultimate goal was, and then how that will drive service improvement and provision moving forward. Again, recognising the excellent service delivery that services are giving to our patient cohort, and that's a huge thing. A lot of services recognise this as a huge and proud team moment of once the accreditation was awarded. And at the end of the day, our ultimate winners out of all of this are our patients. So we're really looking to obviously avoid our 4,400 avoidable amputations each year. And again, having those processes and procedures in place that we know work really well and that are based on the latest research and guidelines is really to the patient's benefit. It gives services direction, particularly through our quality improvement process as well. So any gaps that we identify, any areas that we know need working on, or for whatever reason, we can certainly lead down that way to, again, build a more robust service for the service undergoing accreditation. Services felt that being accredited gave them a bit more leverage within their organisation, which is really positive. And again, looking at quality improvement, sometimes you do need more funding to go down and fill in those gaps that you've identified. And this certainly having the accreditation process, and if you've gone for, say, for example, core accreditation, and within the next 4 years you want to look at Centre of Excellence, it will certainly give you that leverage to work with your executive team on how to get to that point, which is really great. And again, it gave services recognition for their outstanding work that they provide day in, day out. Again, within our survey, most people rated our accreditation process quite high, or very, very high. And again, who would recommend the program to other services? Well, most were a resounding yes, that they would. So where to from here? And I guess expressions of interest are available on our website at any time, and you can put that in at any time. So what we do within that expression of interest form is you identify when your service is ready for accreditation. So for next year, it'll be round 1, 2 or 3, and you pick and you let us know, and then we'll work out how many services we can do at the one time and things like that. But I guess first in best dress, if you get that EOI in quickly to us, then I can facilitate how many services we can go through that process at that time. And I guess the future direction, I guess we want as many services as we can that we know are already providing high-risk foot care to be accredited and to adhering to those standards and the accreditation process. The next step for NADC is to look at re-accrediting services that had gone through the initial round of accreditation, and we have about 6. At the moment, we also know that with the COVID pandemic, it's all a bit crazy and everyone's workload is already quite huge. So what we've proposed to the services that were up for accreditation next year is we've given them an extra 12 months accreditation to sort of work through when the best possible time will be to go through that re-accreditation process. So if they're ready to go for it now, absolutely, we're more than happy to facilitate that. If they need a bit more time, then we can allow that too. But for anyone who's looking for accreditation, please get in contact. And if there's anything we can do to support or to support your service, and also give you a bit more information, then I'm happy to do that as well. And I guess the most important thing is whilst you're going through this accreditation, I'm certainly in contact with those services on a regular basis to chat with them about how they're going, any hiccups they're finding, any explanations they need, or what other services have done in the past to get the accreditation finalised. So you're not alone in this process, and I guess the important thing is we want to support you to achieve the goals that you've set out for, and ultimately, as we've mentioned many a time, is avoid those avoidable amputations for our patient cohort. So I think I'm going to hand over to Georgie now, and we'll do questions and answers. So thanks for joining us.
Hello, thank you, Michaela. That was really wonderful. As someone who is part of the accreditation, and one of my wonderful colleagues went through the process, though it was sometimes a little painful, it's been incredibly valuable for our service. So that's the RPA high-risk foot service. And it also did show just how much amazing work people do, which people don't realise we do, particularly Anna. So thank you very much. I think that was wonderful. Is it nice to be back at work and seeing it all in action?
And homeschooling.
So look, folks, if you've got any questions, or if there's, if there are, Joy's working from home. If anyone's got any questions about tips and tricks and how to be involved, and any little bits that you would like, Michaela is more than happy to answer those questions. And I think, Michaela, one of the things that now that you're back and you're back in the swing of things, have you got any learnings or thoughts that have sort of come to mind since you've been back on track?
Yes, I think from now going through sort of third wave COVID pandemic, there's certainly been a lot of changes to health delivery within high-risk foot service. We know that learning from around the world that high risk was certainly to remain face-to-face as much as we could, but also we know working with a lot of our colleagues, like our ID physicians, our endocrinologists and things like that, will go more to telehealth. So sort of ways that we can work with that group to make sure we don't miss any patient, and to still have the people who might be concerned about coming into hospital for appointments and things like that, that we're still available, and how we can best manage those, the nervousness and anxiety about coming into hospitals, particularly with the COVID numbers the way they are, particularly for New South Wales and Vic. Mm-hmm. Also working with our community health partners as well, to let them know sort of where we're at from a tertiary hospital point of view, and also where they're at. So what we can make sure our regular high-risk foot care is still being provided, and also having those easy pathways in if something does deteriorate quite quick, and also for patients to have the ability to contact their usual care providers for if something does go wrong, that they can manage it as fast as possible.
I suppose this is a little bit for our audience, because we've got quite a big audience of people that are community-based, private, sort of community private together, and hospital-based. I know in New South Wales, just to come into the hospital, you have to have a swab within 48 hours, and it's got to be negative. And so for some of our people who are technologically phobic, that's been quite hard, or people that just find it hard to get around. So we're depending very much on our community members, especially for our patients who don't have mobile phones. So telehealth is proving, you'll call them and it's like, yeah, everything's fine, because neuropathy, it all is fine. And then, 2 days later, they're in hospital with half their foot off. So I'd be interested if anyone wants to put up how do they find in community their workload is increasing? Are they seeing more people? Michaela, you've got to get you to shout into your mic a little bit more.
Sure, no worries, sorry.
No, that's all right. So yeah, it'd be interesting to see how people are going. How are you? So as I said, in New South Wales, we really are starting to block down most of our hospitals. So the two I'm at, and I know Southwest, so it is a little bit different. We're closing down a lot of our services, and we're only seeing, so high-risk foot, we're still seeing people, but it's quite a rigmarole to get people in. How's Victoria going?
Look, we're probably not at the same point as you guys at the moment. We certainly were there last year. So I think we've sort of got some processes in place that we can get rolling quite quickly. So I guess we all sort of know what needs to happen and can do that quite quickly. So I guess it depends on the organisation that you're in and different sort of hotspots and where those services will be at from an organisational point of view, which can be a little bit confusing, particularly for anyone who's working across multiple organisations and things like that. There's sort of different things happening at different times. The information overload for staff can be quite significant, particularly with the change in processes that happen really fast. And as we all know, nothing happens quickly in public health until a pandemic, and then everything happens. So I guess it's just how we manage that as best we can. And we're also definitely what we saw towards the end of last year, and I probably can't really speak for the first half of this year because I wasn't working, but more so we found that we're getting a lot more significant amputations through the doors. So we're getting people coming in who are quite sick, and also really high ballooning amputation rates and things like that. So hopefully once we have a bit more of our data, we will be able to reflect on that. And again, it would be hard to tell if that's COVID related or if that particular patient was going to head down that way. But just in our general experience, we've noticed a lot more are presenting later. And again, that could be, some of the social isolation issues and things like that with what's happening in COVID. So I guess we just really want to look out for everyone as well as our staff. And, everyone's doing an amazing job. The PPE that everyone has to wear, and just, the focus on everyday work. And again, what we're doing is trying to prevent these amputations and prevent these feet and from deteriorating as fast as we can. So I think, checking in on everyone if that's possible, and even the community health partners, and just seeing their workload as well, so that everyone can manage it as best we can.
Yeah, it's quite, we're being deployed, so I'm a vaccinator now. So it's quite an interesting, yeah. So for us, it's been we're doing so many different things that we weren't used to doing, which is great in some ways, but also just devastating with some of our patient loads. So I think the nice thing that we can sort of, where I'm going to move on to is, and I think it's a really good one from, I think, Natalie, was where the standards are going to go for some of the smaller high-risk foot service because they're going to take more of the load now. So I know with ours, the smaller groups are the ones that are taking. There are rurals, there are, who aren't being that affected, but we're not, the bigger sites aren't there to help out as much. So the standards are going to be really important for them.
Yeah, particularly for service development and for new services that are looking at how do we actually establish a high-risk foot service, because there's nothing to stop yourselves from calling any service a high-risk foot service. Particularly, we know that there's private podiatrists that are really capable in high-risk foot, but they don't have that support through medical team around them, but they're still delivering really good high-risk foot care. So I guess NADC is really great at accrediting services and not just individuals. So NADC, if you haven't been on the website, they certainly do a lot of accreditation with pharmacy, diabetes centres, Centre of Excellence for Diabetes, and also digital technology accreditation as well. So we are looking at, as best we can, to move the standards into the community health. And again, a lot of our rural regional services are quite similar to tertiary health, so they still have a lot of those deliverables that can be used within the standards. So if there's any, I guess, queries of that, and we've been in touch with a lot of the regional rural services about how we can accommodate, or if there's just things that really won't work for their setting, we can certainly be, understanding about that and work around that with the standards for them to become accredited. Moving on to community health, again, that's going to take we were doing a bit of work on that last year, then everything kind of imploded. So we're trying to work out how best we can, establish some really robust standards for them, and also put in some sky high deliverables that we want services to achieve that aren't impossible, but will just ultimately benefit patient care. And I think from community health to tertiary health, we certainly want those pathways and connections with the major tertiary hospitals to be there. So how we sort of put that into the standards is still that workable, flexible arrangement we're trying to, nut down and put on paper that won't disadvantage anyone and will allow for that flexibility for demographics as well.
That's nice. Can you give us an example of a sky high?
Look, no, I can't, Georgia, because my brain's not really working this morning.
Brain.
Right. But I guess it really depends on having that medical support within community health. And again, that might be a GP or a physician and things like that. But how else do we get the referral pathways that are clear? How do we escalate care when we need it to be? Because again, a lot of our community partners can really deal with high-risk foot, no problems, but it's the escalation pathways that we need to be process-driven rather than person-dependent. So sort of having those clear parameters around that is probably what we're working on more so. Again, we've got a lot of podiatrists now, as we know, that can prescribe and things like that, and how we work that into a model of care for community health to make sure that they still have that pathway available, that they might not necessarily need that GP input and things like that. And again, having that pathway that's, quite clear is probably what we're looking at.
And I think Nat's also brought quite a nice one. So last fortnight, Joel spoke about some of the data collection, and at the moment it is very focused on high-risk foot services. But as people move down into smaller services, I think you brought up Sinbad and those sorts of things. So we've got very good ways of monitoring wounds. And I suppose it comes into how to refer on. And if you start getting good data processes, you can actually, that's a good way for you to monitor your service and see if you are fitting to best standards. Would that be your sort of take on it as well?
Yeah, I certainly think so. And I think, again, we want to make sure that we can give the support to our community health services to have the availability for us to take on those referrals as well. And a lot of them, it might be for whatever patient reason, they can't come into the hospital and they need to manage them a bit longer and things like that. So we need to be able to support them as best we can as well.
So Gary said in New South Wales, high-risk foot services are scaled across the state as part of the Leading Better Value Care program. That program is based on implementing the ACI high-risk foot standards. Why should our smaller rural services look to another set of standards and seek accreditation?
Yeah, so ACI were quite involved with our standard development, which was for nearly five 5 years ago now when we were developing them. So ACI had their standards out first. Yes, absolutely. And this is looking at a more national approach. So I guess they're quite similar, but, you know, it's probably things that are just on a bit more large scale. So look, if anyone's adhering to either the ACI standards or to NADC standards, would be, you know, really happy with that either way, and that we've got something to look towards, and patients have that reassured knowledge that whoever's delivering that care for them is delivering the best possible care they can, with external service standards that have been, you know, thoroughly debated and thoroughly thought out. And I guess I'm not sure with ACI, I'm not in New South Wales, but I know that, you know, at least with this as well, that you can have that piece of paper to say that you are an accredited service based on those standards. So I guess it's another way of, you know, reassuring patients that you're delivering the best possible care that you can.
And I suppose it's also benchmarking, which kind of brings into the data collection. You know, so if we're benchmarking nationally, we know that we're actually improving. And I suppose it gives you a bit of a check, you know, you're making sure you're reaching these targets, and independent people are actually looking at reviewing the work. I think with ACI, we've got a community of practice, and I know Jackie Caton discusses the NADC standards as well, but they are a little bit more based in diabetes. So some of our rural services in New South Wales aren't diabetes focused.
And I think there's probably, again, quite a national difference as well, that we know that there are high-risk foot services that are very vascular-led, and we know that there are some very endo-led. So we need to make sure we're encompassing all of, you know, all of the high-risk services that we can, and we know that from the Foot Forward map that there is a lot of high-risk foot services out there. And again, they're based, the model of care would be based on the patient needs within that demographic. So we want to make sure we can recognise all those services delivering really great care.
And we've got another lovely little prompt. I suppose the other thing is standardising. And so this way I can put in a little plug for the Foot Forward. So our modules, we've got healthcare professional modules, which they're all standardized, and they're based on the latest guidelines. So how to do monofilament, that's changed slightly, why, and all the background, and making sure that we're all doing the same thing. And it also goes into SINBAD and International Working Group, all the guidelines, but also all the classification systems that are currently recommended. So there is a foot focus. There's a foot ulcer focus ultimately, even though alliteration. So there is definitely the focus on the beginning, so the risk stratification, but then it goes into more detail. So peripheral arterial disease and diabetes-related peripheral neuropathy, which are our bread and butter, no matter what your background. So I think it's the nice thing about all these things is they all encompass and try and draw in and standardizing, give us benchmarks from what we can either achieve or prove that we're achieving, which I think that does kind of bring it together. And look, the link is there if you'd like to go. So I'm going to ask a silly question, because you did sort of answer it, but on average, how long does it take to go through the process?
Yeah, well, I guess anyone who's been through the process, the application section in Standard 1 will give you a slight heart attack. So I guess that was the whole premise with doing the gap analysis tool, is to sort of prepare for all of that as much as you can. We do suggest 2 to 3 full days that will take to enter in on the online platform. And I won't send you the online platform until that accreditation round is open. So there's no cheating. But again, it's pretty much based on the gap analysis tool. So if you have everything ready to go and everything saved and all the evidence saved, then it's a self-directed accreditation platform, and then every criterion that you go through, you'll explain how your service matches that and what you're doing to meet that standard. Then you can provide any evidence that we need to support that claim for the assessors to review. And I guess the important thing to know is explaining, as basic as it sounds, what you do all day, every day. And the important thing is that the assessors that we have are not usually within your state, and are trying to make that as fair as possible. So you need to explain the funding models, what kind of care you have, and things like that. And again, that will be the overarching premise from the application process, that they will then take that through for the rest of that application. So I guess it would take anyone, and again, it would depend on how detailed you want to be. Obviously, the more detailed, the better, but also how many people you want to get involved. So if podiatrist takes the lead, which has been the most important part, and then if you want to get other heads of or other key players like your endos and vascular team to input. And again, that comes into play with a lot of the research that's been done by services as well, that you'll have Highrisk foot research, but again, the endo team might be doing some different research that's still involved with foot, and want to make sure you include those things in the model of care and things like that is happening within that service. So it's always a really good idea to get someone else to review that for you.
Nice. Oh, and Gary, for the Highrisk foot service map, you actually have to apply to go on it. So there's a little form at the bottom of the page where you can apply to put your service on. So yes,
we did do a big that we rolled that out last year, I think. Just sitting, so we sent out. So so anyone who missed that, add on the details.
Just we'll pop it all through because it's now on the Foot Forward page, which is pretty exciting. Looks great, but Michaela was also a massive driver of that, which was great. So it's been a lovely little service. It's a nice, easy service, and it's open to consumers as well. It's not just for healthcare practitioners, though we use it, I think, most often. That's really fabulous. So thanks, Michaela. I think that's been actually really informative, and I think everyone's agreeing that it's been a really informative session, which is nice. And I will say, even though it can be a bit grueling, and of course I didn't do it. So this was my wonderful coordinator, Anna Crawford. I will send it out to her. The feedback was really good, and it has allowed the service to grow. So when you go through it, it is really useful information. So the assessors take a lot of thought in their responses.
And hopefully we can give, some really positive feedback to the service to sort of direct their service planning and to see what other services are doing, or, where we can help support services. And that's why we also give you the choice of rounds to go through, so you can look at your staffing profile and, obviously not do it when everyone's on leave, so you don't have that time. So again, it's trying to, if you can work out when is the most appropriate time and whoever's going to take that lead, it's certainly a really good option to let us know when it would suit you. And again, it is sort of a first come, first serve, as long as you meet all the EOI information, and then we can take it from there.
Yeah, no, I think it's really fabulous. And quarantining the time's important to do it. So
the last week, definitely don't leave it to the last.
No. Yeah. And make sure whoever does it gets a nice little thank you at the end, which I'm sure Anna still hasn't received because we're all been far too busy. All right, so I think we're coming to the end. I'm going to say very, very big thank you to Michaela, and thank you for joining us. Very much, a little bit at the last minute, but it was just wonderful. So absolutely wonderful. And I will like to invite everyone to join us in a couple of weeks, where we've got Dr. Ma from WA talking about their wonderful service. But until then, thank you very much, Michaela, and adieu.
Bye, everyone.
And when stars are in light, the